Hi there, everybody. I'm Aoibhinn Ansbro. Thank you so much for that keynote. It was really interesting to see how a health system in Europe is also facing many of the problems that we see in health systems like Lebanon, where migrants are trying to access the public services, private services, and in a kind of fragmented way. So I'm Deputy Director of the Centre for Global Chronic Conditions at the London School of Hygiene and Tropical Medicine, a primary care physician, so primary care is dear to my heart, and also the research and data co-lead with Angelica Cristello Sarto, who's over here. Will you stand up and give a wave? So I just want to acknowledge all the work in particular that Angelica and all the support that Anna has given us in preparation for this session, which is the research presentation session. We were really delighted to have 30 submissions of abstracts, and we've selected 5 for oral presentation, and there are a number of posters outside, which if you haven't seen them already, have a look around during the next coffee break. So, slightly to set the scene. Well, I was involved in a research landscaping exercise for the WHO high-level global technical meeting in Copenhagen in February. And we looked at all of the available evidence on NCDs and emergencies in high-income and low- and middle-income countries. And while we've seen a really big increase in the amount of publications, especially from 2015 on, there's still major gaps. A lot of the research comes from EMRO, unsurprisingly, and much of it is still very descriptive. It's not high quality, necessarily implementation style research or effectiveness or impact research, but definitely the research and knowledge base is growing. And as discussed yesterday, well, we find research particularly exciting, but also really powerful. And we hope that research will really form a foundation of the work that IATA is doing, and it can support each of the objectives that IATA is pursuing and support all of the activities of each of the working streams. So, for example, we heard yesterday from Helen about MSF's work on the cost of production with partners, which can support advocacy work around reducing the cost of medicines. We heard about the project that the Danish Red Cross, Lebanese Red Cross, and LSHCM are doing in Lebanon, doing implementation research about peer support models of care using implementation approaches, which we hope can interrogate, the quality of care, but also look at things like context, learn lessons that can be transferable to other settings. Obviously, research can support our request for more financing in this area by showing potentially the cost effectiveness of models of care, making the case for NCDs as a topic to actually pay attention to. We can look at feasibility and present these data to donors, which hopefully will help our case. So we're very keen that research would be robust and rigorous, and one of the kind of goals that we have within our working stream is to try to support the quality of research that's being undertaken and support collaboration. So we'd see ourselves as a kind of synergistic, galvanizing body that hopefully brings together a lot of the people who are interested in research in this area to try to collaborate, minimize duplication, and basically work together. More data are needed. I think that's very clear from a lot of the discussion yesterday, both in terms of needing to assess immediate needs for planning and for mapping. We need to know where people are in crises, where stocks are, what's available, what are the needs. There's a massive gap in terms of individual data at the individual level to be able to deliver care to people when they're on the move. And there's huge potential for technology to support a lot of the data needs. And we also need to be able to evaluate how well we're doing in terms of quality of care, but also to hold to account governments, but also pharma companies with their efforts to possibly improve the access to insulin. How do we actually hold them accountable? What are the outcomes that we think are important? Are we asking them to prove that what they're doing is useful? And also ourselves, the humanitarian actors in the room, how can we actually show that the models of care that we're delivering are of good quality? All of that requires data collection. And actually our breakout session this afternoon, we're delighted that a lot of you are going to join us. We're going to be discussing a data tool for collecting data in the first 30 days. So we've done a scoping review through Liz Jarman, who's here with us, and she'll discuss her findings, and we'll hopefully have some interesting insights from people in the room. And then we're going to discuss a list of shared and meaningful indicators, which the informal interagency working group on NCDs has been working on for several years. We're hoping that those efforts will coalesce in the summer and that we will actually decide on a concrete list of meaningful indicators. So not just the number of consultations that have happened, but things that are actually helpful in terms of delivering care and assessing quality. So we'll be discussing that, and then there's going to be a meeting in June, hopefully to make the final decision. So now we're going to have 5 oral presentations. The third one will be by Shatha Albeik, a doctor who works with UNRWA, who has won the prize in terms of the best submission. So we're delighted to have her here in person to present. We have Priyanka Rai, who is the Director of Policy at JDRF. Her presentation is on, it's called the T1 Index. So it's modelling the impact of type 1 diabetes globally, having to fill a lot of the data gaps through modelling essentially. So her presentation is going to be pre-recorded. Margaret Ewan is also here with us, which is great, who's from the Axis campaign, and she's going to present about another tool, which is about monitoring access to insulin. And then we will have Dr. Yusuf Ahmed Mohammed, who's from IRC, who'll be talking to us about a community-based model of care. And then finally, Dr. Shaza Akik, who's from Lebanon, a global research consultant. I'll introduce each of them individually in more detail before they present, but Shaza will be closing this session with the results of a research prioritization exercise that AUB in Lebanon, IRC, and ELRA, the UK-based funder, have been working on for the last 2 years. So they're going to present the kind of key findings in terms of this prioritization process. Disclosures from the speakers are none, and I think we can go ahead now with Priyanka. So if the AV team can help us to bring her recording up, that would be great. Yeah.
Good morning, everyone, and thank you for the opportunity to speak to you all today on the topic of impact of type 1 diabetes in low resource settings based on our 2022 Lancet publication. My name is Priyanka Rai, and besides being one of the authors of that publication, I'm also the Global Access Policy Director for JDRF. And very sorry I couldn't be with you in Greece today. But let me tell you a bit more about JDRF. We are the world's largest nonprofit funder of type 1 diabetes research, and the origins of the type 1 diabetes index are in research. When we started this work, we couldn't answer the most basic questions about the number of people living with type 1 diabetes around the world, where they lived, and how fast was it growing. In response to this growing burden, JDRF partnered with Life for a Child, IDF, ISPAD, and Beyond Type 1 to launch the index, which is now available as a publication, a website, and the code is available freely online as well. So here you can see some of the key global numbers that come out of the work. As on the release of the paper, there's about 8.7 million people living with type 1 diabetes. But more significantly, we think another 3.9 million should still be alive. We also think diabetes is growing really fast, with about 600,000 people diagnosed every year. So how did we get these numbers? Very simply put, we use a Markov chain Monte Carlo simulation model. We created this model and fed it 400 papers from 1890 to 2022, and then we asked it to make predictions about the state of type 1 diabetes in every country on the planet. We've tested these numbers with real-world prevalence data where it's available, and across 15 countries, and we found a median variance of about 6%. But what we do know is that these are some of the best numbers we've had for type 1 compared to previous estimates like the GBD. The index also estimates for the first time healthy years lost, which represents time lost to ill health, disability, or early death from living with T1D. As you can see, this is a pretty significant number across the globe, with an average of about 25 healthy life years being lost due to early mortality. Now, I'd like to share some of the top 3 findings, especially for JDRF. Number 1 is that the research that we've done so far has worked. Over the last 50 years, we've added about 40 healthy life years to the person receiving the latest care. As you can see, someone on a pump in CGM now lives almost as well as the background population. But what we've also found is that the prevalence of T1D is higher in developed countries, but that missing prevalence of people who should be alive is highest in low-income settings. And as you can see from this heat map, it's pretty significant in the global south. Now, the second finding is that the number of healthy years really does depend on where you live. If you're living in France and have access to the latest technology, you get most of your life expectancy. If you're in one of the BRIC countries, you're probably living at, receiving care of the 80s and 70s. So you're losing more healthy life years. But the most dire finding is that we expect that there will be about 6 million missing people by 2040. Most of these will be in low-income settings. So these are people who won't have access to diagnoses and even basic levels of type 1 diabetes care. But that's where the news does start to get better, because we do think that using just-to-taste technology, we can save about 3 to 4 million of that missing prevalence population. It could be access to diagnosis, insulin and strips, and even devices where possible. But we think that can make a huge impact. So instead of sitting around and waiting for governments to act on this, JDRF has started to build a coalition of philanthropic partners who want to contribute to helping reduce this burden. We've got 5 areas on the screen that we are prioritizing at the moment. But what does it mean for people who are caught in a crisis? Well, the type 1 diabetes community is already caught in a crisis. As you can see from all the red on the screen, these are people who don't have access to proper diagnosis, even insulin, rationed, maybe premixed, which is a situation that a lot of type 1 diabetes community already faces in humanitarian crisis. But the index can be a good tool to help there. We're soon going to launch subnational modeling, which will allow us to target where type 1 diabetes population do live and, prioritize aid as we did during the Ukraine crisis. So by leveraging the index, we can help change the trajectory of this condition with attainable interventions such as increased diagnosis and access to insulin and test strips, even in humanitarian crises. So we have an opportunity which, we've never really had access to before. The data is shining a light on where people with T1D live and what are the kind of supports that we need to provide them. So to summarize, I think we now have an opportunity to leverage this resource and to build a coalition that can work together to address the scale and prevalence of T1D and can highlight this opportunity. My details are on the screen. Please do reach out to us if there's any way that we think we can support your work. And congratulations on this conference. Really looking forward to some positive outcomes from this meeting. Thank you all.
So our thanks to Priyanka. Unfortunately, she couldn't be here or be live, so we could ask questions, but I think it's a really clear example of how research work can produce evidence that we can then take to philanthropic funders, as she said, with very concrete action points linked to evidence and show people where the problems are and galvanize people into action. So next we have Dr. Margaret Ewan, who I invite to join me up here. She works for Health Action International, an NGO based in Amsterdam, and Margaret currently co-leads the Addressing the Challenge and Constraints of Insulin Sources and Supply, which I call ACCIS. I'm not sure if that's how you pronounce it. So we're delighted to have you here with us, Margaret.
Good morning, everyone. I'm going to very quickly try and give you just an introduction to what we call our main tool, monitoring access to insulin. And I just want to acknowledge that this tool has been developed by both Molly and myself and is being used in 4 countries, but we'll get to that. So the importance of monitoring, well, we heard yesterday about the real need to understand the situation in a country, even in times of stability, let alone when there is a crisis. But, you know, surveys, a number of surveys have been undertaken, but often when you actually need the data, it's out of date. So what we need is up-to-date, good information. The thing also is a lot of the surveys, they identify the issue, but they don't give you any idea of the cause of the problem. So that's an important part in trying to monitor as well. And the surveys that have been done, and we've done a lot of them too, they've been facility-based. But what we really want to know is what about in the household with a person who has type 1 or type 2 who uses insulin. And of course, yesterday we talked about the WHO 100% target. That needs to be measured. And we actually, to do that, need a definition of affordability. And we do keep asking WHO to work on that, and I hope they are. But that's an issue too. Sorry? We are. Good. We'll talk later, James. So this main tool, well, we've developed it for ongoing monitoring, but it can be used for a one-off survey, looking at availability, prices and affordability of insulin, the delivery devices and blood glucose monitoring devices. Also looking at the testing itself, both self-testing and testing where you go to a facility and get tested with either a meter or a strip, and also HbA1c testing. We ask questions about rationing and a whole lot more questions that I'll come on to. We're also currently looking at assessing household expenditure as a percentage of income for insulin, the delivery device, and the self-monitoring device individually and collectively. We're also looking at assessing progress in achieving the WHO target, and James, let's compare notes. Also assessing percentage of household with catastrophic spending on insulin and their related supplies. So we're just at the moment in 2 countries collecting household income data to do this new aspect of the main tool. So data is collected from facilities and also from, as I mentioned, from households. A mix of households, some with it's type 1 diabetes and some with type 2 who use insulin. Data is collected by phone to be more sustainable because with monitoring there's a whole issue of sustainability. But we do periodic validations where we go and check what was given, the information given by phone, to actually go to the facility and the household and double check within 24 hours that what was given by phone is the reality. The data gets entered into an app and there's automatic analysis in dashboards. It's currently being used by Stefan, Moisey and the team in Santa Diabet in Mali, and they've done 4 rounds. In Kyrgyzstan, Peru, they've both done 2, and Peru's just finishing their 3rd, and Tanzania is just completing their 1st round. We greatly support transparency, and we hope by the end of June, well, we're working really hard to make it happen. By the end of June, all the dashboard data is all going to be on our website, so you can access the whole data set, which is so much more than what I'm going to be talking about, because I don't have a lot of time. So just to give you a little bit of a taste, this is the findings from Kyrgyzstan, from their data for last year. They surveyed, monitored 53 facilities in the public and private sectors, and 292 households remained in the Sentinel sample. This is just availability. This is in the public sector. In Kyrgyzstan, insulin is free in the public sector, so the public sector is extremely important. This is availability by INN and also by brand. So this is the top 10 brands on the side, and you can see they're all Novo and Sanofi products. No biosimilars were found. And as I mentioned, very little is, this is a public sector where you get your insulin and only 2.8% availability in the private pharmacies. So then I was looking at the trends analysis between 2002 and 2003 to see, well, is availability in the public sector increasing or decreasing? And this shows you that it was increasing except for NPH, where it had gone from 76% down to 59%. Hello, what's happening here? So then I went to the household data. And here, this is just a couple of the analysis. One is products both available and unavailable. And of the 17 households where what they were using was unavailable, 17 were NPH. And then we asked, well, what if it's not in the home and you should be using it, why not? And in all but one case, it wasn't available in the facilities. And when we looked at NPH in particular, all cases said it's not in the home because I could not find it in any facility. So then I looked at the rationing data. Is it being rationed? And in last year, 21% of the households said they had rationed their insulin within the last 3 months. And you can see by type 1 and type 2 there's a difference, which, is not surprising, but certainly concerning, particularly with type 1 being rationed. The reason for the rationing, in all cases, the insulin wasn't available. So you can see there's a definite supply issues last year with Protofane, and it was the same the year before. And when they're currently just doing their monitoring now, and I worry that the same situation will be there. Novo Nordisk was contacted about this and said, yes, we have supply problems and it will be fixed, we hope, by the end of this year. It's difficult when you rely on one company when this sort of thing happens. And I would honestly suggest that the government of Kyrgyzstan look at, split tenders so that they're not so reliant on one company when this sort of thing happens. What about prices? Well, I said free in the public sector, but in the households, 10% said they are actually paying for their insulin. And you can see overall, human insulin was about $9 for 1,000 units, and analogues were $26 for 1,000 units. So a big difference between the price of human and analogues. And you can see on the right, this is the price by INN, and the biggest variation was seen with glargine. Now I'm going to quickly jump to blood glucose testing. So this is, first of all, we ask, well, in the last month, we ask each household, had you had your blood glucose tested? And 93% said they had. Households where there'd been no testing, 4 of the households were the person had type 1 and hadn't tested at all in the last month. 35 had type 2 and were using insulin. Another question we asked, well, what's your primary device for measuring your blood glucose? And on the left, it's type 1, and you can see 3/4 of the people are using meters and strips, 23% are using a CGM. On the right, type 2, again, it's meters and strips, 24% aren't self-testing at all. Has that changed since 2022? Well, this is for type 1 diabetes, and there is a doubling of use of CGMs. It's still low for all the households, but it has increased, and the number of people using meters and strips has gone down. But also there's increase in the number of people who don't self-test. This is type 1 diabetes. I haven't shown it for type 2, but there's been little change from 2022 to 2023. We ask about frequency of testing, and you can see on the left an average of 25 tests in the last week. For type 2, 4. But big variations, and you can see for type 1, the vast majority of people are testing over 20 times in the last week, said that they had tested. Test strips in the home. We know the price of test strips can be high and a barrier to use. So we ask about this. 93.7% of households said that they use meters and strips, and that they had test strips in the home at the day of the monitoring. Where it wasn't in the home, we asked why, and you can see there was a mix of reasons given. It's available in the facilities, but it costs too much, or it wasn't available. So, you know, this whole strips issue is a problem, because so often they have to be paid for out of pocket, and price can be an issue. Talking of prices, in Kyrgyzstan, the insulin may be free in the public sector, but the strips are not. You have to go generally to the private sector to get your strips. They're not free. And you can see on the right-hand side, the median price for one strip in US dollars was 24 cents. But there's a variation in prices. And I looked at the year before. The price has slightly gone down from the year before. The median was 27, but the variation in price wasn't as great as it had been in 2022. Now, I've just put this in because this isn't something that we'd really thought about, but we saw this happening in Peru, so we added this in. And we asked, how many facilities did you have to go to get your supply of insulin, or your supply of syringes, or your supply of test strips? And this is for test strips, and again, this is Kyrgyzstan, and you can see 20% of people reported having to go to 3 or more facilities to get their test strips. And I've just looked at the data from Peru, and it's quite common for people to say 8 facilities, even 10 facilities. They've really had to shop around to get the number that they needed in that supply. This is an issue. So just in concluding, this is just a quick snapshot. We do all sorts of demographic analyses by gender, by years since diagnosis, by income, and whatever. And when the tool is online, you know, I do urge you to go and have a look at it. It is important to regularly monitor, to understand the situation at all times. And I think this tool does provide evidence. It can be a good baseline for humanitarian crises when they happen, as invariably they do. And we have found in these countries that the ministries of health and others have expressed real interest in having a tool that identifies some problems for them. So thank you, and over the breaks, if you've got any questions, and we encourage countries to do monitoring, come and talk to Molly or myself, and we can make the tool available to you and talk more about it. Thank you.
Hello. So we do have 2 minutes for questions if anyone wanted to ask Margaret anything about the tool at this time. I'll go to Irina and then Bayard.
Hello. Thank you very much for very interesting. I know situation in this country very well. It's really sad. But what is your opinion? Because you're deep involved in this research and know situation. How we can help change this situation to change? Thank you.
Well, to me, a key issue in Kyrgyzstan is this supply problem that's currently happened last year, happened the year before, and I believe we're going to find it's still happening. And I do think there has to be discussions with the ministry on their procurement, and they should diversify. We need to look at what's registered. We have to encourage, quality assured biosimilar manufacturers to register. And as I say, I really think awarding tenders to the lowest bidder is, one, it stifles competition, and two, I think it can put you in a vulnerable position like they are in Kyrgyzstan. So I think we should now think about split tenders so that you can quickly get more supplies from another source that's already supplying. But of course, we have to be very cognizant of people who, of course, are using a particular brand, they're stable, they're happy and everything. We don't want people to be having to change brands, if they don't want to. Of course not. And as we talked about yesterday, that requires education of doctors and the insulin users themselves. But I think we have to relook at procurement, particularly in Kyrgyzstan. When I see stocks out of stock and people not using the insulin that they should be using, that really is worrying.
Does this work? Yeah. Thanks so much for the presentation. It's really interesting. Could you just say a few words about the sort of response rates that you got? I don't ask this to question it at all. It's more the opposite of where you might have a sort of very motivated sort of study population, if you like, how that can really support further research in this area, where you're able to demonstrate kind of high response rates and sort of encourage more work in this area. Thank you.
Do you mean from the households
Yeah.
themselves? Yes, That's a good question. And actually, Stefan would probably be good to talk about in the Mali experience. But actually, because we asked, is there anything else you want to tell us? That's, one of the questions in talking to households. And I've just looked at the Peru data. Nearly every household had another comment. And actually, that information is so valuable too. And I'm really encouraging the partner in country who collects the information and uses the information to really go through those comments. And a lot of people, particularly those with type 1, are saying, thank you for asking me about this, because nobody else has. But of course, there is also a fall off. Some people have passed away, sadly. Some people, type 2, no longer use insulin. And there are some people that say, no, I don't want to tell you anymore. But I think I know, Stefan, you're starting to bring in the diabetes groups in Mali to work with them to also encourage the feedback from the households, because you do need a robust sample, particularly if you're analysing by region within the country. You really need to have good regional representation in the numbers. So I think working with the diabetes groups in the country will enrich the whole experience and the use of the information. It's one thing to get the information, it's another thing to use it.
Yeah, thanks, Mark, for the presentation. Respect hugely the work that you and Molly have done and the whole Exes team over the years. My question is really just sort of directed at you and your anxieties, if you have them, about access to test strips going forward. I think, in 2024, we're seeing CGM, continuous glucose monitoring, being the absolute norm when it comes to monitoring glucose control in well-resourced settings, not just purely as the next sort of frontier in diabetes management, but really as a huge tool in improving clinical outcomes and quality of life and mental well-being. It definitely keeps me up at night wondering about the future of access to test strips, because I fear that we're in a sort of purgatory right now for people who still cannot access test strips of which are often more costly to end users than insulin is. And we have been in this sense of urgency around access to test strips for years and years now. We know how expensive they are. We know how often people have to pay or don't pay out of pocket for them because they simply can't afford. And I just wondered kind of what your thoughts sort of on, while organizations may be working on access to CGM for vulnerable settings and lower income populations, while we're working on that as kind of the holy grail, what is happening now for access to test strips? And do you have any anxieties about this?
just on this whole issue of blood glucose testing, we've just done a study in 6 countries, low and middle income countries, just on the devices. And what we've found is the huge cost of sensors, huge cost. So as costly as the test strips are, the sensor prices are beyond the reach of so many of the population. It's only for the wealthy. And indeed, when you talk to the manufacturers of the sensors, they say, well, their income is generated in countries that reimburse the price of the sensors, not people paying out of pocket, particularly in low and middle income countries. It's a fact that at the moment, until we get CGMs and whatever device people want to use into universal health coverage, we are in a position where we have people using meters and strips. I do really get concerned about the cost of the test strips. It's clear. And now we ask people, would you like to test more than you do? And what we're finding, the reason they're giving us is that the test strips are too expensive, but it's also the pain of the pricking of the fingers of the skin to get the blood. That has often also now been given as the reason. So it's not always the cost, but cost is an issue, and they're telling us that. So I think, I think we've got to absolutely urge in universal healthcare, for those on low incomes, there needs to be free insulin and there needs to be free devices, delivery devices, and there needs to be free blood glucose devices. It's the only way. But in the meantime, we've got to do something to lower the price of blood glucose testing so that people test closer to the recommended number of tests they need to do, rather than when you see the numbers they're actually doing. Do I have anxiety about? I have anxiety about everything. I'm a Catholic. Between anxiety and guilt, we have it all. Thank you.
Sorry, last question.
I might just keep them relatively short. We have one more online, so we'll just keep them quick question and quick answer.
I'll be very quick. My name is Nupur. I'm from India. I live with type 1 diabetes and run a community-based organization called Blue Circle Diabetes Foundation. Are there any plans to, expand this to other countries? I know this would be hugely helpful in South Asia, for example. The way things are, it's very haphazard. There's a lot of out-of-pocket expenditure in my country, in India. And the second part of my question, who are the multiple stakeholders? I understand from your presentation, Stefan and others, community-based organizations are involved, but are ministries of health involved from the start as well? And how can we help as organizations? Thank you.
Well, I have to say, as I near the end of my career, I would love all countries to be monitoring, to be honest. I really do. I think I'd love to see this tool used as in many countries as possible. And if any of you want to use this tool, we welcome it and we will provide support. We can't provide financial support. We don't have the funding to do that. But we would certainly provide the technical support. And even in my retirement, I'm going to be still helping out with this sort of work, because it's really important to have up-to-date, comprehensive information. Yes, the Ministry of Health, we encourage all our partners that do this to do it with the Ministry's support and involvement right from the start. Particularly, you are collecting data from facilities in the public sector, so you need it anyway, but you need their buy-in support right from the get-go. So I encourage that, whether it's using the main tool or any other survey you do, you really must get them included from the start, rather than go to them at the end and say, oh, look what we've done, now do something. It'll be much easier if you get their support at the beginning.
Thanks, Mark. You've already actually addressed the online question, which was, wouldn't it be worth exploring other causes for not testing other than non-affordability? So you've addressed that. So thank you so much. I think this was a really, really interesting presentation. Shows obviously the use of this tool for advocacy around insulin availability, strips availability, and also the potential, if there is a crisis in any of the countries where this has been performed, that you at least have some baseline data about the types of insulin used and so on. So now we're going to move on to Shatha Albaik, who is from UNRWA, who's here with us today. She's the winner of the oral presentation prize. She has a bachelor's degree in pharmacy, a master's of public health from the University of Jordan, and looks after the UNRWA health program response team, coordinating the emergency plan and supports all of the research that UNRWA is doing. So welcome and thank you.
Okay, good morning, everyone. It's a pleasure for me to be here today. I was happy when I heard yesterday that I'm the winner. I was not aware that I am the winner. I was just for the thing that I was selected part of the 5 abstract, but it's of course, I'm not the winner. Too many people are winning today with me, and you will see them through this presentation. So today I will be quick. Today I will talk more about our emergency response in terms of handling the medication in general, and here in this session for the diabetic medication in Gaza recent escalation. The story started in 7th of October, in which we were activating our emergency response. 6 days later, UNRWA, as mentioned by Dr. Sita yesterday, has to shift its operation to the southern part of Gaza. Thus, we lost our medical supplies, inventories, of course, with the medical supplies. And for insulin, as everyone was talking yesterday, with insulin, we lost 92% of our insulin, the main 3 types in the warehouse. Of course, this is not the end of the story. There is many other approaches has been done to make our supplies in with the operating health centers. When we went to the southern part in Gaza, we had some logistic base, small one called Rafah logistic base, in which the insulin syringes were there, so we didn't lose the insulin syringes. We were having almost 6 months supply of insulin syringes, and then we have to activate another immediate actions beyond our existing protocols and SOPs and procedures. In principle, we were asking to procure 6 months supply for all our medicine and medical supplies. This is the main strategic response that we have started with. We also, to replenish many other supplies, we conducted an interfield transfer between the medication in our warehouse in Jordan to the warehouses in Gaza. We were approaching all our suppliers and established suppliers, especially for insulin, to accelerate our deliveries, the ones that we were already on order, and then thanks, they were doing this with a very efficient supplies and a very efficient timeline. We lost our warehouse, but we rented a small warehouse in the area between Rafah and Khan Yunis, and this is the warehouse that we had. It's not an ideal, but it had saved our medication and our supplies. End of the video, you will see the people behind this. So those are our people who are managing the supplies in Gaza. Of course, for insulin, here I'm also talking, we have our own established suppliers in which we have our long-term agreement with, but because of the issues of the stock, mitigating the deliveries issues and mitigating the stock out issues, we have reaching out many other WHO pre-qualified manufacturers, in which one of them was Egypt as mentioned last time. They were also now having the Eli Lilly manufacturing. On top of this, we have our collaborative support with WHO for the NCD kits, and which we already received our NCD kits module 1, in which most of our medications are there, and we managed to distribute it to our health center. Insulin analogs, yes, MSF, we reached you. Sylvia also contacted us with many MSF colleagues to both inside Gaza and outside in different parts of the world. Unfortunately, we were stuck out of insulin analogs. It has been delivered to Gaza almost in March, after almost 5 months of the crisis. but we can understand why. We have too many issues in the deliveries, too many issues in the manufacturing, cold chain, and many other issues. But still, we also have to navigate many complex logistics issues in which you may all heard about. In UNRWA, first 30 days of the response, we have worked with the Jordan Hashemite Charity, and we were supplying Gaza with them through the military aircrafts. But what we were doing is that we asked our colleagues to check on our medication. Are they really loaded on the perfect way? Perfect way or not. So we are also in Arish, the second photo, we are handling those medication, and of course this is a random check for the cold chain. Ensuring continuity of care. Now we have our e-health system that all our medications and all our medical supplies are monitored through this system. We call it subsystem. Because of the internet connectivity, because of the electricity cuts, and because of shortage of staff, we were not able to track our supplies in the proper pre-escalation time. But what we did is we simply create an Excel sheet, and we start working together inside and outside Gaza, people in the headquarters, people in the inside Gaza. We were trying to add physically on the tally sheet and reflected on the Excel sheets what we are issuing and what we are receiving. On top of that, we were able to be part of the logistic health cluster of medical supplies. This is the link in which you can find that UNRWA managed to, until today, to deliver almost 6 million medicine in terms of value, and 3 million are on the pipeline. Within the findings, now, as I said, our e-health system have some hiccups, but of course our other monitoring tools can manage what we are doing. We have to see the average consumption of our medication, anti-diabetic medication mainly, not only insulin, but also the oral diabetic agents that I don't think we should ignore. Consistently, most of those medications were on the same average monthly consumption. So this is the cold chain facility that we are having to save insulin. From this table, you will find that we are bringing insulin and insulin elements from different parts, from Denmark, Dubai, Egypt, and others. And then you will find when are our insulin reached. In insulin, mainly here I'm talking about insulin premix, the first item that was replenishing in Gaza in November, and then we start receiving the other supplies by March. So the main items that was supporting Gaza population is only insulin premixed. Question is, did we receive and did we reach our beneficiaries whom are on insulin? The answer was, I don't know at the beginning of the time and at the beginning of submitting this abstract, but within time we were able to extract more data from the e-health and the observations and the notes taking from our colleagues. So within the e-health, we have issued 187,000 vials of insulin premixed. When we go through those transactions happening in the database, is it going to the health center? Is it transferred from a health center to a medical point? Is it transferred from a health center to a shelter or others? And we could confirm that 80% of those vials have been administered directly to patients, which is good, right? Okay. On the other hand, if I want to see not only the vials, I want to see the NCD visits. Do our patients come to our health center? This is the question. So we find out that those are the diabetic patients. We have 61% of those diabetic patients come to our centers at least like from 0 to 2 times. And then you can find end of the graph that 3 patients come to our health center more than 13 times. We were saying, this could be a data entry issues. But when we were digging in the data, we were seeing that, yes, this is a patient going to the health center 13 times and took their medication because they have been displaced all those times. During the last 6 months, they were being displaced many, many times. So you can understand the situation that we are going through. On the other hand, For oral anti-diabetic agent, we were sure that 65% of our diabetic patients also received their medication. Challenges and limitation. This photo will show you that those are the pallets. The pallets here are used as doors to separate the rooms and to separate the pharmacies. So even within this situation, we are utilizing those things to support our infrastructure and our facilities. So we lost our medication with a continuous displacement from our colleagues, from our population. Insufficient storage space, the one that you see in the warehouse, and the one that is here in the medical center, it's very small, you see, and it's very condensed in terms of space. Okay. Again, this photo will show you the screen of the e-health system. It's not working. And the pharmacist at that time, she used to work on the e-health system until it's by luck come back, she will go back and use it, but then she will continue working on a tally sheet. So we have limited access to electricity, limited access to internet, which is difficulty in the system. Again, conclusion. Conclusion is that, do we successfully sustain our insulin supply in Anor Gaza? Yes, and this is mainly because our people in Gaza and also our people outside Gaza. So the last picture you will see the boss. Where is he? Raise your hand. And our other boss, Dr. Zuhair, is also joining us online. So both of them and also people inside Gaza are working on this to make sure that supplies are available. Finally, what we are advocating for today. We are advocating to sustain this provision of essential medication, mainly for insulin. We are advocating for necessary resources, not only medication, all what support this medication and medical supplies to support Gaza population, not only Gaza refugees, and of course continue collaborating with our partners, and of course rest in peace to all our colleagues who have been killed in this crisis. Thank you.
Thank you so much, Shada, and we applaud you and all of your colleagues' efforts to respond to the crisis and keep people going with their medications despite all of the immense challenges. We have time for just one question, I would say. If anybody has a question from the audience, we'll go to Beatrice.
Thank you. So if I understood correctly, you were getting some of your supplies from the Eva Pharma manufacturing in Egypt, right? And I wonder, did you find it helpful to have insulin made in Egypt in terms of price and speed of availability, or did it, not make any difference in a way?
So first of all, as I mentioned, we will have to check that if we can purchase those insulin from other manufacturers that we are not working with. But when we got the confirmation to proceed, yes, they were delivered in 3 days.
Okay.
Exactly. It was like we need to make sure that to mitigate a risk of stock out for insulin, because the delivery process from Arish to Rafah, from Rafah to Gaza, and those inspection procedures. But when we order those quantities, the price was reasonable. But in terms of delivery, 3 days, and it was entering Gaza.
Okay. Thank you.
Any other questions? No, we'll move on. Thank you so much, Shata. So we have 2 more presentations which are online, but can I ask everyone in the room to just stand up for a moment and just get your energy flowing again? So if you want to shake your left hand. Well, Irina, come and join me. Okay. I don't know if many of you remember Irina. Some music. We hadn't planned this. So stand up, shake your hands in the air, and down to the floor. Swing your arms. So I think we're putting our hands together in a prayer-like movement and then twisting to the side. All of you online, I hope you're doing this at home as well. or in the office? Okay. Few chunks. Be careful. Okay. Okay, last one. We're going to twist, twist. Okay, thank you so much. Okay, wonderful. And thanks to the AV team for the music. Okay, so next we have Yusuf Ahmed Mohammed, who's with IRC, who's joining us remotely. He's a public health professional with over 12 years of experience working to design and implement programming. He has worked with MSF in the past and is currently with IRC, as you can see. So thank you so much for joining us, Yusuf.
Thanks, Anna, and thank everyone in the meeting. As Anna said, my name is Yusuf Ahmed Mohammed. I'm non-communicable disease program officer working with IRC, Somali Country Program.
Yusuf, if you can hear me, let me know if you need me to move your slides.
Okay.
Okay, or you can share your screen if you prefer.
Yeah, I'm just going to share my screen. So let me know if you can see my screen. Is it okay?
We don't see it yet.
How about now?
No, we don't see your slides. Can we share them from here? We should have them on the slide deck. We don't have
okay.
them.
Okay, share it.
Okay. Okay. So Anna is going to share her screen.
Okay.
So Yusuf, while we're working the slides out, do you want to just give us a brief introduction? You can start presenting your first slide and then we'll show it when we're able.
Okay.
Thank you.
Okay, thanks everyone again for giving us this opportunity. The study is about experience in the role of community health workers, primary health care, or direct after acting primary health care in humanitarian setting. The study also is based on health facility as well as safely carried out in the community. Okay, next.
If you go ahead and then we'll share the next slide in a moment. Thank you. Yusuf, would you go ahead and just tell us the content of your next slide and we'll share when we can. Oh, great, it's up now.
Go ahead. You can look at the light.
And the next.
The prolonged conflict, oh, sorry.
What would you like to go ahead from here?
No, the past slide, yes, thanks.
Thank you.
The prolonged conflict and drought caused by climate change has been severely impacted by the Somali health infrastructure people living with non-communicable disease face challenges due to the system inability to provide adequate care of NCD, the limit available of NCD sources. According to the Somali Demographic Survey for 2020, the Somali NCD prevalence is 6%, which accounts on high or leading that hypertension is the leading one, 3%, as well as diabetic is 20, following the other NCD. As well as one of 12 adults of Somalia living NCD in Somalia. Next. International Rescue Committee implemented a non-communicable disease community-based in Somalia, especially South Somalia, in Banadi region, Mogadishu, the capital city, which hosts around 3 million people. Next. Oops, sorry. Okay. Okay, to promote NCD prevention, the project enhances the capacity of the community health workers to provide NCD health education sessions to the community, including home-based follow-up check, and as well as distributing relevant health education sessions to the community, as well as screening at home. Next. In 2023, IRC carried out a health facility-based survey in Banadi region, especially in the project target locations, using a mixed method approach, including quantitative gap survey, as well as focus group discussion, key informant, as well as desk review. Next. The aim of the study was to know the knowledge of the NCD clients, as well as perception of the people living with NCD. 271 clients were interviewed during the survey, of whom 50% were diabetic. The exclusion criteria was not referred clients by the state health facility. Additionally, the IRC assisted with the Federal Ministry of Health in establishing policy setting, as well as coordination in collaborating with MOH. IRC also trained CWs on NCD. Next. In January, the project strengthened or improved the referral system at a different level, like national, community, and as well as facility level. To promote NCD health education, the project empowered the community health workers to provide or conduct health education, as well as conduct blood pressure and blood sugar check-up at household or community level. As you can see, the photo is one of the community health workers performing a blood sugar test for a client during World Diabetic Day. Next. Significant improvement in the community knowledge was documented. A 22 increase from 63 baseline to 85 end-line survey was also identified or noted, as well as the attitude of the knowledge of community practice shows that 22%. Additionally, the community health workers educated at community level for the 2,175 individuals on NCD at community level. Next. Here we have the result of the end-line cap survey, starting from the left slide, which is also talking about increasing consultation over time for diabetic. Between 2022 to 2023, there was an increase of diabetic consultation around 28%. at facility level, as well as the graph the right side also shows us people referred with community health workers who had a diabetic on, as well as attended to the health facility. We see a high proportion of referred clients visit to the health facility. As you can see in the graph, 98% of the people that the community health workers referred from the community to the health facility went to the health facility and they received treatment services in the health facility. And this shows us a high percentage of increase of the people with diabetic seeking healthcare at this health facility. Next. Here we have two graphs. The left graph also shows us source of information about NCD. During the survey, we assessed the source of information as well as the trusted. As you can see, 95% of the clients or respondents said we received the NCD information related from the community health workers. The second is the outreach activities following the others. As well as the graph into the right side, which is about the information source of trusted, which are the most information sources people trust. As you can see again, CW is the top one, shows us 72%, following to the average activities conducted by the community volunteers, which shows us 48%. So what graph is this? It shows us that the CW are the most trusted and the most source people get the information compared to other canals like radio, TV, or maybe text message or something else. Next. Here we have behavior that impact the NCD management positively on the right, on the left graph. As you can see here, people and they have some knowledge on behavior change. As you can see, 49% of the respondents said people who have a low salt diet, as well as secondly, respondents they said as 45% with minimal physical activity, whereas the least is people who smoke. So that you can see that the people have some knowledge according to the impact of the NCD management related. The second graph, which is the right, is about the people's knowledge of risk factors of NCD. As you can see, people, they have some knowledge on this. 98% said physical activity, as well as excessive use of salt, tobacco use, especially smoking, following the rest like processing food and so on. So that you can see that the survey finding is that most of the respondents, they have some knowledge on behavioral change as well as the knowledge of risk factors of NCD as a result of community volunteers, health education result. Next. Somalia is experiencing increasing number of NCDs. The CAW are they have the role to promote diabetic service uptake through providing health education insurance as well as follow up at house level, as well as referring to the clients to the health facility. Next. Here we have a lesson learned, and here we have increasing or strengthening what's called community health workers, as well as community, as well as health workers and community health workers was trained and strengthened as a result, so that the referral system has increased due to this training. Next, as we have now currently, the program uses what is called ComCare, which is a mobile health digital system for collection of the data. CGB also was trained of this app so that they collect information is for clients to this application, so that availability of the data used for decision making is also improved. Next. Due to the distance as well as insecurity, there was an accessibility of health facility for the clients, as well as limits of national data at country level. There was scarcity, especially lack of national data collection tools for the key indicators at national level. Although currently the Ministry of Health are working on improving or already developed some NCD indicators, but previously there was no any, there was a challenge or there was a gap of national data NCD. Next. What is planned or may, or it can be also as a recommendation, we are recommending to carry out formative research, as well as we are also committing revise to IATI guideline for NCD. We're also recommending as well as to support the non-communicable disease technical working group for advocacy to continue the advocacy for policy level, as well as in collaborating with the Ministry of Health. We are recommending to what they call it, to engage the private sectors to reduce the cost of referral cases. And finally, we recommended to enhance the quality of the community health workers through regular training at community level. Next. Here we have a photo for one of the community health workers and a client. The community health workers is currently conducting or educating a community member at home, is discussing or showing or addressing with lifestyle change, the importance of lifestyle change, as well as eating healthy food, using what is called a health education materials translated into the local language to make easily understanding for the clients. Next. Here we have another photo for another community health workers. Yes, currently the community health worker is conducting a session at home for some of the people living in the target locations. The community health worker currently is just discussing with the clients their knowledge and understanding of the risk factors of NCD using locally translated health education materials. This is one of our CWs. We usually visit to the community level and conduct a community level session at home to educate the community, as well as to screen and as well as to refer and link it to the health facility. Next. According to this photo, before I read the photo, I would like to go what is the background of the information. IRC and as well as Ministry of Health of Somalia developed a training curriculum consists of two guidelines, one for facilitator and one for student. The guidelines consist of 6 models, including cardiovascular disease, hypertension, diabetic, and so on. And then IRC and the Minister of Health, they trained these guidelines to 85 CWs, of 74% of them were females, to improve their skills of NCD prevention at community level. So currently the photo shows us ongoing training session, some of the CWs currently making it as a group work as part of their training. Next. Thank you very much. Over to you.
Thank you very much, Yusuf, and apologies for the technical difficulties at the beginning. In the interest of time, I'm just going to take the chair's prerogative and ask the question myself. Did you manage to show any change in behaviours in actual diet, exercise, smoking rates between the beginning and the end of the intervention?
Thank you, Anna. The project, in order to also to improve the behavior of the community, the project already started hiring some community volunteers from community level. The project trained these CWs how to engage, how to mobilize or sensitize to the community how to on the behavior, starting from diet, like exercise. Because before we start the property, some of the community they had not enough information on NCD. Some were also going to the traditional healers. Some were always staying at home or do something else. So after training these individuals, we also feel improvement of community behavior. As you can see, the slides we have presented, the behavior of the community has been improved as a result of the project. And this is the only NCD program currently running in Banatu region at facility level, at community level, integrated to primary health care. Thanks.
Okay, thank you so much, Yusuf. Thank you for joining us from afar. We really appreciate you being here. And now we're going to move on to our final presentation, which is from Dr. Shaza Akik, who is a public health research consultant from Lebanon, who has a DRPH from the London School of Hygiene and Tropical Medicine, and her main areas of interest are non-communicable disease and nutrition. And she's been collaborating with LSHTM, Danish Red Cross and the Lebanese Red Cross on the peer support group intervention evaluation that we've been talking about during the last couple of days. So Shaza is going to present on the ELRA AUB IRC research prioritization exercise, and I know many people in the room here have contributed their technical expertise to this as well. So welcome, Shaza. Thank you for joining us. I think you're muted. We don't hear you.
Can we try? Hello, can you hear me now?
We hear you now.
Perfect. And I'm going to share my screen. Sorry, just a second. Oh my God. Okay, where is that? So, can you please confirm once you can see my slides?
We're still waiting.
Yes.
Great, we can see them now.
Perfect. So thank you very much, Aveen. Thank you, everyone. So today I'm presenting on behalf of a wider group from the IRC and AUB about an exercise that we, as Aveen mentioned earlier, that we conducted over the past 2 years, and that is really a research priority setting exercise for NCDs with a focus on cardiometabolic syndrome. So we all know there is a high burden of NCDs in humanitarian settings, particularly in protracted crises. The management of NCDs is often deprioritized due to limited resources and competing demands. And the ability to respond is challenged by frequent disruptions in access to care. Cardiovascular diseases, including cardiometabolic syndrome, account for around globally or over 20% of the burden of disability. And so really, here our focus is on cardiometabolic syndrome, a cluster of 5 CVD risk factors, as it has rarely been addressed. So the aim of this research priority setting exercise is to generate a consensus-based research agenda that will steer NCD research focused on CMS in humanitarian settings for the next decade, 2023-2033. And so the methodology that we adopted was really an adapted child health and nutrition research initiative approach, which is the CHINRI approach. And before we go into the details of it, it's important to highlight that all of this work has been in consultations with, we had a steering committee, we had a technical subcommittee, and there was a strong engagement of the interagency working group on NCDs. So for the different steps of this exercise, first of which we had to specify, obviously, the country. So what did we include? And we decided to include all populations that are affected by any type of a humanitarian crisis. And that is, at the global level, regional, national, or local level. That is also accounting for, taking into account any outcome of interest. The second step was to really look at which criteria against which to score these questions. And with engagement from the technical subcommittee, we selected 4 criteria against which we were going to score each of the questions. And these were impact, effectiveness, feasibility, and deliverability. And the first survey, so to source the priority research questions, we deployed a first survey that was guided by evidence maps. We received input from 182 respondents with around 700 questions, which we consolidated through a thematic process into a list of 43 priority research questions. We took these 43 questions and sent out a second survey where we asked our respondents to score these 43 questions against the 4 criteria that we had selected. When we closed the survey, we calculated the average scores and the average agreement score for each of those priority research questions. Sorry. And then we obviously got the feedback of our steering committee and technical subcommittee and revised our findings before submitting a final report. So looking at the characteristics of the survey 1 and survey 2 respondents, specifically looking at regions of work, we can see that we had a high representation from the Afro and EMRO regions, both for survey 1 and survey 2, with less representation from Southeast Asia, Europe, America, and the West Pacific regions. In terms of profession, also we can see that we had a high representation from healthcare workers, health program managers, and coordinators for both survey 1 and survey 2. We also had around 20% of respondents being researchers, whether in academic or non-academic settings, and then less representation of technical experts, representatives of professional bodies or funding organizations or governmental organizations. And then also we had a category for others. So if we look at the findings, unfortunately, we don't have the time nor space to present all 43 priority research questions and go into the details. So really today is really a very quick snapshot of what we found. So on the right, you will see a table with the top, so the keywords of the top 10 priority research questions. And we can see here that really the top 10 priority questions were related to outcomes and processes of care. And this, given that healthcare providers were the majority of our respondents, we believe that this reflects actually that this is an important thematic area for them that is that they have presented to us through their answers. But also this shows a call for prioritization of implementation and intervention research, or identifying what works for patient care within humanitarian settings, context or settings, compared to the previous, or what I would say, the evidence that we already have where there's a lot of focus on epidemiology, burden of diseases, etc. The second set of findings we're going to present are the lowest ranking questions, and we're just presenting one group of questions, and that is related to financing. So we have 3 questions, as we can see in the table on the right. And so again, when we were reflecting on why, we expected that the financing questions would rank at the top, but that was not the case, and we're trying to understand why. First of which, we thought that NCD financing is a neglected area of interest that is not typically part of the healthcare workers' day-to-day engagement. And so since there are a majority of our respondents, that could explain it. But also this could be explained by the fact that the fundamental questions around NCDs in humanitarian settings are not yet answered. So the focus is not yet on financing, or it could be that there's no earmarked NCD funding within the health sector funding. So if we look at the strength of this exercise, we involved technical experts and NCDs in humanitarian settings, as I said, and our steering committee, technical subcommittee, and they were engaged in all steps of this exercise. We had a strong survey dissemination strategy, and we did not allow for partially filled surveys. On the other hand, we have to recognize that to acknowledge that the majority of the survey respondents were health professionals working in the field in the Afro and EMRO regions, and so this could explain why we saw a skew in some of it could have skewed the results that we got. The other aspect is that the length and the structure of the survey may have impacted the response rate. So since we did not allow for partially filled surveys, and we had 43 questions, and we had one question for each of the criteria, so 4 questions per question, that was a long survey. And it is possible that this could have affected our response rate and caused a scorer fatigue. So in conclusion, the research on this exercise has highlighted that the research on NCDs with focus on CMS needs to prioritize models of care for people with NCDs in humanitarian settings, including processes and outcomes of care. It needs to prioritize quality, effective, and integrated primary care for NCDs. And so healthcare workers are keen to understand how best to prevent and manage NCDs in these settings, how to use patient-centered approaches, and how to maintain the continuity and sustainability of care, as well as, so there's the need to also prioritize the research on task shifting to community health workers in humanitarian settings. Also, we noticed there are major gaps around financing and analyses around cost effectiveness of research and interventions in humanitarian settings. And so really, further research is needed to systematically address this burden of NCDs. And so our call for action messages are to really allocate funds towards CMS research that builds evidence on NCD care and prevention in humanitarian settings, to conduct research that is, to research cost-effective intervention models focusing on implementation outcomes such as impact, acceptability, feasibility, with a contextual understanding of need by priority area, and to use patient-centered approaches and include voices of people living with NCDs to help determine and center their preferences and needs during the implementation of the NCD research. Thank you.
Thank you so much, Shaza. We actually thank you for actually sticking to time as well, which is wonderful. So that means we've 4 entire minutes for questions. If anybody wants to ask a question to Shaza, please.
Thanks, Avina. Thanks, Shaza. I had a question about something that I don't think was mentioned very much, which was health policy and translation into well, both national level policy and then translating that down into action. So I was curious about the fact that wasn't mentioned in the, I don't think it was mentioned in the lowest ranking questions or in the highest ranking ones. It feels to me that there have been a few important WMA, World Health Assembly resolutions in the last few years, both before COVID and afterwards, about strengthening NCD integration in health emergency disaster risk management. And regional WHO regional offices are working on regional frameworks, but quite a different way across the different regions. And I know that at least in 1 or 2 countries, including Yemen, the Ministry of Health has started looking at implementing this framework at national level. So I guess the question is, I was thinking we might see some respondents saying this is actually going to be important to look at these health policy initiatives, which ones are working. Did that not feature because respondents said it wasn't interesting, it wasn't important, or was it that was there an underrepresentation of people working on the policy side?
Thank you very much for your question. And I don't have a 100% answer, but I would say it is possibly because we had an underrepresentation of representatives from, organizations working at the policy level. And that was despite a very strong dissemination strategy that we adopted. So we disseminated the survey on every possible platform that we could think of. But unfortunately, despite that, we still did not receive enough answers. And I think, yes, unfortunately, it did not come up as part of our questions. And I can even, we initially received around 700 questions, and we skimmed through, obviously we worked through each of them, and this did not come up strongly, I would say. I cannot recall this coming up.
Hi, good morning. Seita from UNRWA. Question is that how you translate this what you have done into the real research and also address, more important, address real needs. Because, yeah, I understand the ranking is very interesting, but maybe the top ranking is something all of us wonder what to do, but don't know what to do. And the bottom of the ranking could be the breakthrough. And so that the ranking may not be reflect to the real needs or may not be reflect to the real impact at the end, particularly when we are wondering what to do in CDS. So I think it's good to ask to the operation person like me to ask what to do, but I give you lots of stupid questions, but one of them could be the breakthrough, and I think that's part of the exercise is very much important, particularly for the NCD. What do you think?
Thank you very much for your question. And I agree that it's not easy. So now it's about really, the first step is to conduct that research. And then based on the findings, we can then translate the findings into policies, into programs. But for the time being, it's a call for research. It's to fund research on these priority areas that have been identified by operational actors on the ground, programmatic actors who said these are relevant questions. And so we want to understand these before we implement and we develop any policies.
Thanks, Shaza. Any other? We'll do one last question and then we'll close.
If I can just comment on that. In fact, I think this presentation set the stage well, and I invite you to come to the diagnostics workshop this afternoon, because the aim is really to discuss what implementation research can we conduct very practically to improve access to diagnostics in that case, right? And I think this research exercise here in prioritization is going to be a useful tool to mobilize resources and get, speak to funders, basically. So I think that really is the key, right? And with that research exercise, and that coming out so much at the top, giving it a very strong argument for moving forward with some funded work.
Thank you. And I would like to just mention that we're launching, so the official launch of the report will be on the 27th of June. And so if you're interested, of course, we're going to disseminate it. We still don't have a link to share with you, but if you're interested, please keep an eye on Alra's page, and you'll have all the details for the launch, and where we will go into more details into the results, but also into the implications of this work and how to take it further. Thank you.
Thanks so much, Shaza. Thank you for joining us. And we hope to move forward together in terms of helping to answer some of these research questions, including in all of the breakout sessions this afternoon. Thanks again. We have one comment from Irina about one of the earlier presentations.
Yeah, thank you very much. I would like continue to Margaret research, and I only want to present IDF Europe work. You can find this information in IDF Europe site, country profile. And this profile, some countries have already done. We collaborate with member association, and then you find some information, how many strips, which care available, which not in country profile. Please go. Thank you.
Thanks, Irina. And one last plug. So this is a survey that the Genius group within ISPAD is doing. And do we have Denise here? Denise, do you want to just stand up? So it's about the care of young refugees with type 1 diabetes. It's a survey aimed at healthcare professionals, mainly within the public system, but beyond that also. So they'd be very grateful for your help in disseminating this survey. They have had responses from certain countries, but there are gaps from other parts of the world. So through your networks, if you could disseminate this, we'd be grateful. So thank you, everybody, for your attention for the last hour and a half plus. We've seen some really interesting uses of data, which will help to support advocacy and care responses, some new tools and modelling efforts that are already underway. We've also seen two examples of responses. So one in an acute crisis where people are using data to support the delivery of medications and tracking of supply chains, and where a new model of care has been developed in close collaboration with the Ministry of Health, improving referral systems and strengthening community-based care. And finally, an effort to bring everyone together in a consensus in terms of what are the research priorities on cardiovascular and metabolic conditions in humanitarian crises going forward. So there's a lot of energy in this room, and we hope to galvanize, it's my word of the day, galvanize, build on all of this energy and come up with some kind of concrete impacts in the afternoon sessions to move on, a lot of that being underpinned by good quality, robust research. So thank you again and enjoy your coffee.
Yeah.